Bienvenidos en nombre de la Fundación ALPE. Para los que no me conozcáis, yo soy Susana Noval, soy la coordinadora de la Fundación, pero con nosotros también está Carmen Alonso, que no quiere aparecer aquí en la ventanita, pero bueno, como todos conocéis, ella es la directora de la Fundación. Estefanía González, que es la directora y encargada de proyectos, y Sonia Sestelo, que es la encargada de todo el tema administrativo. Bienvenidos en nombre de toda la Fundación, evidentemente de nuestro patronato, que evidentemente es el soporte, ¿no?, principal, y es el que gracias a ellos podemos seguir trabajando y dando todo el servicio que intentamos dar habitualmente, ¿no? Esta es una nueva charla dentro del ciclo de ADEE Expertos, Ventanas ALPE. Sabéis que es un ciclo que empezó el año pasado con este confinamiento, con nuestras ventanas ALPE a nivel nacional y a nivel muy cercano, y sí que en este 2021 hemos decidido intentar darle todavía una dimensión mayor, ¿no? ¿Por qué? Bueno, pues porque las ADE, para los que no estéis un poco identificados con este acrónimo, cuando hablamos de ADE hablamos de acondroplasia y otras displasias esqueléticas que causan enanismo, para no dejarnos a ninguna y además para evitar siempre esa connotación peyorativa que a veces vemos, escuchamos y algunos usan cuando se combinan los términos enanismo, displasias, discapacidad, esquelético, en fin. No es oficial, pero sí oficioso, llevamos utilizándolo casi más de un año y creemos que es positivo y estamos viendo resultados positivos. No nos dejamos a nadie, abarcamos todas las displasias que causan enanismo y nos evitamos ¿no?, esos tonos peyorativos. Entonces, ¿qué pasa? Que las ADE están consideradas dentro de lo que son las enfermedades raras o poco frecuentes, como nos gusta a nosotros llamarlas. ¿Qué conlleva eso muchas veces? Poca información, a veces poco estudio sobre ellas y a veces lo que hay es poco accesible, ¿no? Entonces, pues nosotros nos hemos propuesto intentar hacer una buena divulgación del conocimiento que hay, también, bueno, incentivar ¿no?, y exigir un poco más de estudios sobre ellas y también, divulgar y trabajar sobre las buenas prácticas y sobre el manejo, ¿no?, de lo que son las displasias esqueléticas. Intentar hacerlo llegar a todo el mundo, personas afectadas, sus familias y profesionales que habitualmente también trabajan con ellos y que o bien tienen poca información o bien poco acceso a ello. Entonces, esos son un poco los objetivos principales de este proyecto ADEE Expertos, y en el que nos hemos propuesto intentar abarcar también desde el punto de vista del que trabaja la Fundación, que es desde un punto de vista integral, ¿no?, desde una perspectiva integral de la persona. Entonces, abarcar los temas clínicos, abarcar los temas de investigación, abarcar los temas educativos, los de derechos humanos y derechos sociales, intentar darle ese enfoque global, desde la perspectiva global de la persona, que creemos que siempre es la mejor manera de hacer un buen manejo y un buen trabajo. En este caso, y hoy nos acompaña la doctora Theroux. Ella es anestesista pediátrica en el Hospital DuPont de Delaware. Está dentro también del grupo de William Mackenzie, que también nos acompañará la semana que viene. Y nosotras tuvimos el gusto, el honor y el lujo, hay que decirlo así con todas las palabras, de conocerla en el 2018 en nuestro Congreso Internacional aquí en Gijón, en el que fue invitada también para hablar sobre el tema en el que ella es más experta, que es en el tema de la anestesia y las displasias esqueléticas. Y evidentemente, pues aparte de la exposición magistral que dio en su momento, lo que también nos encantó fue esa cercanía, ese cariño, ese trabajo durante todos los días del congreso con las familias, no solo con su momento de exposición, sino el compartir todos los días, toda la vida que se vive, ¿no?, durante esos 3 días de congreso, todas las dudas que le surgían a las familias, todas las cuestiones que le surgían a otros profesionales. Pues ella estuvo muy atenta, muy cariñosa, muy cercana y de hecho pasó a formar parte de este equipo tan amplio que intentamos hacer en la Fundación de asesoramiento, ¿no?, continuo. Cuando llega algún problema, alguna cuestión por parte de familias o por parte de profesionales relativo, en este caso a la anestesia, intentamos derivarlo a ella y ella siempre está ahí. Tengo que decirlo, entonces aprovechamos este momento para darte las gracias públicamente por tenerte siempre, no hoy solo aquí, sino siempre tan cerca de la fundación, tan cerca de las familias y tan cerca de todos los profesionales en todas las partes del mundo que te necesitan. Así que, bueno, sin más, te doy paso, como protagonista que eres, te doy las gracias públicamente de nuevo y estamos encantadas de tenerte aquí, aunque sea a través de esta pantalla, y de tenerte siempre, de sentirte sobre todo siempre tan cerca en nuestro equipo de colaboración y de asesoramiento de la Fundación. Antes de que empiece a hablar la doctora, solamente una cuestión. Si a lo largo de su exposición tenéis alguna duda, hay una opción que es preguntas y respuestas, podéis dejarlo ahí, ¿vale? O en el chat o ahí, pero bueno, aquí queda todo bastante ordenado para que la doctora pueda resolverlas y incluso si alguna quedase pendiente se la enviaríamos por email y ella nos la responde, bien ahora o bien porque os surjan las dudas después, ¿no? Porque muchas veces recibimos la información y cuando la procesamos es cuando a veces surgen dudas. Bueno, pues también podéis hacérnoslas llegar a nuestro email de la Fundación, que lo voy a dejar ahora en el chat por si alguien no lo tiene, y también se las podemos hacer llegar a la doctora posteriormente. Así que yo creo que sin más, doctora, pues cuando quiera estamos encantadas de volver a escucharla y de volver a verla.
I see that there are 19 Q&A already. Does that mean anything? Can you?
No, yo creo que ha habido un error. Creo que ha habido un error, pues alguien se ha confundido y no sé,
Okay.
No sé qué ha hecho porque es lo mismo. Es como un número de teléfono continuo y creo que no son, no, creo que no, bueno, creo no son preguntas. No son preguntas en concreto, es un número de teléfono y no sé qué, no pone ninguna pregunta en concreto. Entonces, bueno, el espectador que corresponda a este número o a este nombre puede dejar su pregunta por escrito. Pero vamos, hasta ahora mismo no hay ninguna, así que no se preocupe.
Okay. Okay. Can everyone see my screen? Can no?
No.
Hang on. I think I need to go to share my screen. Yes, I see it. How about now?
Sí, perfecto.
Okay, great. So skeletal dysplasia, I thought I will stick to talking about, what is dear to our heart and everyday life, which is managing, from an anesthetic standpoint, which is managing a trouble-free anesthetic, skeletal dysplasia, and among, many other difficulties in life, I think have some unique difficulties with anesthetic, which well managed can easily produce a good outcome. Let me ask you again, can you guys hear me? All the participants can hear me? Yep, okay, great. Thank you for your kind words, really great introduction. And you can see I'm from AI DuPont Children's Hospital. I work with the skeletal dysplasia team, and I have been here for 31 years. I am an old lady. And thank you again for inviting me. So, as part of any talks that we give, we have to disclose that we do not have any connections to any organizations that we receive money from, or we are owning stocks in their companies or anything like that. I have no financial connections with any anything related to skeletal dysplasia. So I'm supposed to announce that. I did dance with many of you guys at the Gijon meeting in Spain. And those are the pictures I have down here. This was in the clinic, and this was at the Sidra Center that we all had a great time. And this again, this picture here was at the clinic again. So that's my disclosure, that I had a fantastic time with everyone there. So the goal today, again, how to provide a safe anesthetic, and what can you as patients do to help yourself, be an advocate for yourself, and what can you ask the anesthesiology or anesthesia folks back in back where you are. We anesthesia providers over here in the United States get called anesthesiologist more often, and in Europe, mostly they're called anesthetist. It's just a difference in the word. They mean the same thing. It is a large topic. If I cover, all the common skeletal dysplasia, but for the most part, I'm going to stick to achondroplasia and difficulties with that particular skeletal dysplasia. And I will briefly just touch upon Markio syndrome, and which is a mucopolysaccharidosis, which has a very unique issue. And I know that you guys have some patients, and I have gotten, I think, 2 or 3 consultations from there. So just in case those patients are out there, I wanted to just touch upon that. So the risks from anesthesia are things that patients only think about it when they have surgery. On a daily basis, they're not thinking about it, right? While other issues, pain from lumbar stenosis, or there's breathing difficulty needing CPAP or things like that. That's a daily issue. But the risk from anesthesia are, and rightfully so, you're not thinking about it on a daily basis. You think about it when you have an upcoming surgery, and that's fine. It's just that at that point in time, you want to see what you can do to make sure you have a safe anesthetic. An ALPE website, I was going over it the last week, has a lot of good information about the general problems that achondroplasia has, but I didn't see much about anesthesia risk, and that's common. And a lot of the websites related to skeletal dysplasia often do not say a lot about anesthesia. And again, that's why we are here. We are here to help, and any questions you have, I'd be happy to answer. So you see literature published, not a lot, but there are some about lungs and airways in achondroplasia, right? Look at this article. Do little people have little lungs? Now, they immediately go on to talk about lungs, which are important for anesthesia, but for us, it's the airway that get us and get our patients into trouble. And I say our patients get into trouble, we are in trouble too. We have to, it's our our life's goal to provide a safe anesthetic. So, but this is a good example of how literature is published, where they look at general system involvement, but not touch upon specific aspects that relate to anesthesia. So what are the parts of especially the upper respiratory system that are important to us? And I speak about this every time, and if I'm repeating myself, I apologize in advance. I just want to make sure that everyone out there understands what, you know, when you see doctors, they talk about upper airway, lower airway, and what do they mean? And what, you know, what makes upper airway, and lower airway, lower airway. So when a patient goes to sleep, we have to manage first the upper airway, which starts with, you know, with the nostrils and the mouth, going down to the oral cavity, and also the space behind. Can you see my pointer when I point with my mouth? Okay. So starting with the nostrils and the mouth, it goes down towards what we call oral pharynx, which is the oral cavity, the mouth cavity, plus the vocal cord, the beginning of the larynx. So upper airways, nostrils, oral cavity, tongue. Tongue becomes an issue, not that it's part of the breathing system, but it tends to obstruct the breathing system. So that's where the tongue makes a difference. And most dysplasias, skeletal dysplasias, the tongue in relationship to the size of the mouth, it's larger than it should be. So it tends to be sitting there occupying the mouth and not allowing a lot of fresh gas to go through. And then there's the epiglottis. Epiglottis is this structure here that protects the airway from when you eat, you know, you don't aspirate, and that's because the epiglottis comes and closes the airway for us, and that's called the epiglottis. It's a small structure, but that's part of the airway. And there are the vocal cords. That's the beginning of the trachea. And what is the lower airway? Lower airway is the trachea and the bronchi. So this is the beginning of the trachea. This whole thing is the trachea, and it goes or separates into upper bronchus and the right bronchus and the left bronchus, and the right bronchus supplies the entire right lung, and the left bronchus supplies the entire left lung. That's how we breathe and takes air into our lungs. And so all of this, any part of this being obstructed, you know, as you can imagine, causes problems. So that's the basic anatomy that we are dealing with. So what does it mean when, you know, when a doctor or an anesthesia person tells you, do you have a difficult upper airway? Again, when a patient goes to sleep under anesthesia, we use this mask, and many of you probably experienced this. We use a mask. It doesn't quite look like this, and different countries use different color, different variety of masks, but pretty much the idea is the same, and it's placed on the patient's mouth and nose. And initially the patient will breathe for himself or herself, and then as they get more and more sleepy, we will breathe. As you can see, this person's hand, he's squeezing this kind of plastic bag, pushing air into the mouth and nose and down, all the way down to the lungs. So it seems simple, but in skeletal dysplasias, because of the change in anatomy, it often becomes difficult. So when we say that there's an a difficult upper airway, it can be this part, going back to, so when we breathe for the patient, that air has to go all the way down to here and then down to here and to the lungs. So this whole what we call induction of anesthesia, beginning of the anesthesia, is all about that. So we have to have a clear and open airway in order to introduce oxygen and the anesthetic gas that puts a patient asleep. So why in skeletal dysplasia this is difficult? It's because of, I'll get to this slide in a minute. It's because of many things. So the skeletal dysplasia patients, again, if we were to only talk about achondroplasia, it would be that the children and the adults have, in comparison to the rest of their body, they have smaller nostrils, and not only small in the outside opening, but as it goes behind, back to this picture, as it goes behind, it starts to narrow, especially behind the nostrils. It tends to be narrow. And the trachea, especially in children, they are, the trachea is smaller in diameter. So there is that difficulty. And the other main difficulty is the size of the tongue. So we have to somehow displace the tongue. And there are ways to do that. As I go through some more slides, I'll show you how to do that. So, and there are other difficulties as a patient goes through different phases of disease treatment. There are other difficulties, and those are when a patient has neck surgery and the neck is fused. And I'm going to skip a couple of slides to show that. So this is a patient with difficult intubation. He was 42-year-old male. He was just having cataract surgery. Luckily these days for cataract surgery, you don't actually need anesthesia, general anesthesia. They put local and you don't actually need to go to sleep. But this was a few years ago. And this patient's neck is very abnormal. And there are two vertebrae here that is, one is lodged into the other, causing a very severe kyphosis. It's meaning there's a forward bending of the spine. Forward bending of the spine that causes severe deformity of the trachea. So, well, we do see patients with, especially as they grow older, when the spine becomes somewhat deformed in many different ways. Why did this patient get into difficulty? The patient got into difficulty because the patient's anesthesiologist was not the same person who anesthetized him before. So this time the anesthesia person did not know anything about the airway and thought, he'll be okay, and put him asleep. And lo and behold, the airway is difficult. Now, if there is what we call continuity of care, meaning there is information passed on adequately, not only that, the possibly if it's the same person or same team anesthetizing the patient, they would know all there is to know to manage that particular airway. Oftentimes, many times, that's all it takes. So it is really important that you do your research as patients and make sure the anesthesia person you are facing knows about your difficulties. Ask them to find the anesthetic charts from before, and that will go a long way to making things safer for you. So this person, the previous anesthetic record was not available, and nowadays that's not an excuse. In most countries, you can, even if it's not an electronic chart, it is possible to find information about patients. We didn't have electronic charts till, maybe 10, 15 years ago, and I've been here 31 years, right? So we were always able to get information. So it may take a couple of phone calls, but it is well worth it. And so, if they had gotten the information, they would have found out that they had difficulty with intubation before. And ultimately, they perform what's called a blind nasal intubation, which is not commonly practiced, and they got lucky and it worked, but it's not really advisable, and it can be traumatic. So this case happened in 1966. So to some degree, you can say maybe that was justifiable given was so long ago, and maybe information that we have now they didn't have back then. So I showed you that picture. This is one of our own patient who, this is another reason how the upper airway becomes difficult. This patient's neck has been fused solid. You can see the instrumentation here. And this patient cannot move the head and neck at all. There is no flexion, meaning forward bending. There's no extension, meaning backward bending. None of those movements are possible. So that make it difficult for us to open mouth and place the breathing tube. And even with that mask ventilation that I showed you, by that I mean, let me show you again. This part, it's difficult because we have to lift up the face and the jaw of the patient. And in a patient like this, you cannot lift anything up. So then we have to do, what we call as sedated fiber optic intubation. Now, I'm sure some of you have heard or have undergone a fiber optic intubation, and again, it can be safely done. It's safe because you're not putting patient asleep and risking losing the airway, because if there's any difficulty, there's always the option for backing out and saying, okay, for some reason this is not working, or choose another option. But so this patient is a candidate for awake fiber optic intubation, and we know that this patient has had that before. We have all that information. So yeah, I went over this already, but I just want to add that in certain dysplasias like storage diseases, like mucopolysaccharidosis, which Markio syndrome is maybe almost a prototype of that particular type of dysplasia, because they need a lot more surgical procedures than some of the other MPS type of dysplasia. So they have deposits which are storage material that should be broken down by the body, but they have enzyme deficiency that causes the storage material to accumulate, and therefore and it accumulates, unfortunately, in the trachea and in the bone. But trachea, of course, is a very important organ for anesthesia folks, and that becomes a problem. So how do we manage patients? This is a standard intubation laryngoscope, we call it. Every country has it, every anesthesia department has it. And this is the, every operating room will have 2, 3, actually maybe up to 5 or 6 different sizes of it. And it's how we anesthetize and intubate most patients without difficult airway. This just happens to be called a Miller blade. There's one called a Mac blade, but that's really not important. It's just proprietary name. And with that blade, we look directly like how this video is showing you. Okay, it's the next one. We look directly into the patient's mouth. That is a breathing tube my resident is placing. Again, I'm going to show it to you. And because the mouth is wide open, the neck is tilted back nicely. There's no problem doing it. It also looks a lot easier than actually it sometimes is. I'll show it one more time. It's a very quick video. And it goes in and everything is good. Now, when we have a patient who is difficult, this is a typical example of an achondroplastic patient's intubation, where we just need some help with this particular instrument. This particular instrument will not work. And it's partly because the tongue is too large, the tongue needs to come out. And also because the movement of the head and neck is not quite adequate. So then we go to this particular device, and again, every anesthesia department in most of the countries have this particular equipment. It's called a video laryngoscope. There are a few different companies that make them. We use GlideScope and CMAC, which is a Strauss brand, and this is a GlideScope. So this first I'm picking up the tongue with the gauze piece. The patient is asleep, so she doesn't feel any of this, and placing the blade behind that tongue, because I have to get enough room there, right there, to place that tongue. And then I'll show you a video of that, but the breathing tube is going through the vocal cord, and you can see that. But here is a video of it. Can you see that? Are you able to see it? No?
No, este vídeo no aparece, Mary.
Yeah, that's a separate video on my screen, so I have to share the screen again. Let me see if I can. I'm afraid
No, seguimos sin
I
verlo.
don't, yeah, I don't want to maybe
No te
during
preocupes, no pasa nada.
okay, I'm thinking during the Q&A time, because I want to spend some time answering questions. I had another dysplasia meeting last month, and there were a lot of questions, so I do not want to cut short the question and answer time.
Dicen, perdona Mary, dicen que puede ser que tienes que compartir la pantalla completa, que tienes que dar a pantalla completa porque lo tienes como minimizado. Nos dejan aquí en el chat.
Okay.
Darle a maximizar, quizás pantalla completa.
Go to Zoom and choose whole screen.
¿Lo ves?
Share.
No, primero maximizar, tener la pantalla completa porque la tienes como minimizada. Darle abajo a pantalla completa de presentación de PowerPoint.
So my I don't see that comments and notes. I have chat, Q&A, new share.
Pues no.
This
Ahí.
one maybe.
A ver ahora.
That doesn't allow me to get to the video.
Bueno, no, pues no pasa nada. No pasa nada. Puedes continuar y probamos si no al final, como has dicho.
Okay. Yeah, I will, while I'm talking or answering questions, I can try to.
Perfecto.
So I just wanted to
Vale.
show you the fiber optic scope. One of the things I would really like to do is, have the patient see what these scopes look like. Fiber optic scope is it's an indirect view where we're looking through. See, I'm looking at a screen. You can see me looking elsewhere. This is the screen I'm looking at. I'm not looking at the patient because if I look at the patient, I can't see anything. And so I have this video at the end of the scope, which is showing me what I need to see on the screen. The fiber optic scope is a little bit more advanced than the video laryngoscope I showed you, and therefore needs a little bit more skill, and it would be nice for you to make sure that your anesthesia person is comfortable with that, and that's another question you might want to ask, especially if you've been told that you have a difficult airway. And while I am talking about, airway tools, we often use this particular device called LMA. LMA stands for laryngeal mask airway. It has been a lifesaver of an airway that was introduced about 25 years ago, and slowly gotten better and better. And when we can't, if we have a new patient that we don't know anything about, they don't know they're difficult, and it's a new anesthetic or first anesthetic, and we find out that the patient is a difficult airway, we can buy time using this particular device and keep breathing for the patient. And we can also intubate through this little opening here. It goes, so this part of the LMA sits behind the trachea, and so we can actually put the breathing tube through here and pass into the trachea this way. And it's a well-known and nice way to do a airway management. And it's not as well known as it should be. It's one of those things. It just needs more time before more people get to know. It's easier to do than the fiber optic intubation. So well worth checking into it. So and it can be used in patients who have enough mouth opening. If the mouth is so tight that the mouth opening is less than 14 millimeter, then the LMA it has that little bit of a width. It's like a cushion. It has to go into and behind the tongue, so the mouth has to open just enough to place it. Now, I just want to touch upon the other anesthetic aspects. I don't want it to be all about airway. What are the other concerns? So the cesarean section and labor and delivery units have their own difficulty with successfully placing a spinal or an epidural in achondroplastic patients. And the literature actually has a little bit more case reports on this particular issue than airway. Actually, airway just hasn't been published. It should be published, but whenever there is a bad outcome, then the cases don't get published. With spinal and epidural, when there is a complication, it's usually not an extremely bad complication. So the medical world goes ahead and publish it. And so there are a few more publications out there about this particular aspect of the care of skeletal dysplasia. Now, spinal and epidural anesthesia, I just want to say right up front, are contraindicated in mucopolysaccharidosis patients, especially in marquee patients. But we have written in many places, actually, when I say we, I mean I, that it is contraindicated. There have been too many cases of spinal cord infarction. So this doesn't apply to achondroplasia patients, but if there are patients with marquee out there, I just want them to know. And again, going back to the literature about epidurals and spinal anesthesia, Spinal is more commonly done for cesarean section, and some patients, it just won't be successful, and it's unclear exactly why that is. It could be that the pregnancy makes for a little tighter spinal canal, because they can get into the spinal canal, but there's a fluid called CSF that is cerebrospinal fluid. You have to see that fluid coming out before the spinal anesthetic can be put into the spinal canal, and oftentimes they just don't see the fluid coming out, and if that happens, they have to abandon, because otherwise the anesthesia will fail and the cesarean section cannot happen, and they have to move on to a general anesthetic. And the other thing is that in a pregnant patient, it's a little more difficult to find the spinal space. And nowadays, for the last several years, an ultrasound is used, which doesn't cause any radiation. X-ray cannot be used because that will cause radiation to the patient and to the infant. And so ultrasound being used is very helpful. So that's again another point or another helpful hint when you talk to your anesthesiologist, especially the OB, the obstetrics unit. By that I mean, the department that takes care of pregnant patients and the delivery of pregnant patients. Again, I have seen patients where they have had 3 children. The first child, they had a successful spinal anesthetic. The second one, they failed. And the third one, this is a particular patient I happen to know, and she was being evaluated as to whether to attempt a spinal or just go on to an epidural. And I think they are going to try a spinal with the ultrasound. And if they fail, they will move on to doing a general anesthetic. Something called combined spinal epidural. It's been reported in one instance, but I think it's probably not really necessary, and maybe a little bit too much of a procedure for a cesarean section. If a spinal works, which is the easier one to do, epidural is really not necessary. So I think maybe it is, not all publications are meant to really be practiced. Sometimes things are published just to have literature published for that particular department, to show that they're publishing enough material. Going back to the other extreme age, which is the infants. Infants more often come for MRI of their brain. As you know, they can have the foramen magnum stenosis, which is not it's right at the base of the skull, which is part of the spinal cord, but it's not the vertebral column itself. It's the bottom of the skull being too narrow for the spinal cord to exit from the brain. And luckily, achondroplasia is not a dysplasia where instability of the C1, what we call C1, C2, C3, those don't occur commonly at all. So it's most commonly the foramen magnum, that base of the skull stenosis that we see, and it leads to apnea, poor feeding, and hypotonia, meaning lack of tone, and that muscle tone that you need to have. And back in the days, it used to be the infants would be operated on for this very quickly, but nowadays the neurosurgeons wait and see if the infant can grow out of it, unless they have some criteria as to when they will intervene. So at that point, the infant will have an anesthetic in the operating room and have the foramen magnum decompressed. And it's not a difficult anesthetic in those situations, especially when the infant comes for an MRI, because MRI, you don't think of the anesthesia part as much, but anesthesia is still anesthesia, right? No matter whether it's for MRI or for surgery. And in an infant having MRI of brain, we here we provide general anesthesia because they want to get super clear MRI pictures where there is no, the infant does not move, and if the infant moves, they don't get clear picture. And so they would want at least one MRI of the brain and spine done with a general anesthesia. So when we do those anesthetics, we don't use any opioids. And opioids, by that I mean, things like morphine or fentanyl, things that have a mu opioid effect, because that causes, it depresses respiratory effort and leads to increased apneic episode. So we manage without using opioids, and that's very helpful. And the other thing that these infants sometimes have is croup after waking up, because the airway, most skeletal dysplasia in infancy, including achondroplasia, the airway is particularly small. So even when we use the tiniest tube possible, when the tube comes out, the infant might be a little croupy, and usually it can be treated with steroids very effectively, and we keep the infant overnight for 24 hours, and they go home the next day. In the teenage age, as you know, lumbar stenosis is more common, and unless the airway is difficult, it's not a difficult anesthetic. Still, there are things that the anesthesia folks need to watch out for. The temperature under anesthesia, and because the achondroplasia has that there's a profuse sweating and easily rising temperature, even when they are not anesthetized. So under anesthesia, if we cover the patients with warm blanket, and we typically use a forced air warmer that is meant to keep the patients really warm, but they don't really need that. Or if we use it, we have to make sure we turn it off as soon as the temperature starts to rise. Otherwise, the temperature can get pretty high, and then they will start, if they didn't know that this can happen, it can be alarming to the anesthesia folks. Other skeletal dysplasias do this as well, but achondroplasia quite consistently does this. And as most parents know of children that I see, they will give a history of the children sweating, and they don't really like a lot of blankets on them. It's all part of that same issue. So, I'll just finish with saying a couple of things about the trachea of Markio patients. That it's a relatively recent finding. We first recognized that in 2015, January of 2015. The patient came in acutely obstructing. Before that, the patients were obstructing, but we didn't know what it was. But then we realized this is what's going on. So several different patients' trachea, and they all have this, pretty significant narrowing of their trachea. And some of these patients have had surgery to resect that. This does not really happen in achondroplasia patients. And if it happens, it's extremely rare and for some other reason other than what makes Markio patients have this. So it's not of a major concern, but again, I just wanted to make sure because this is something that we are trying to get across to the rest of the world. And we get lots of questions from many different countries. So every chance I get to speak, I mention this. Okay, so we're trying to wrap this talk. What can the patients do besides, all of what I talked about? We do recommend that if you are a known difficult airway patient, to have an emergency bracelet. There are organizations that will provide that, and here we try to get it for free for our patients, or sometimes the patients will get them themselves, and it costs only a few dollars. And some of the patients here have my phone number on their bracelet, which is fine. I know many of them, and if they end up in the emergency room, the emergency doctor can call me. And a lot of the patients, I don't really even have to look at their chart to know what the airway difficulty is. Of course, the other relatives' names and things like that. This is our skeletal dysplasia team. This is Dr. McKenzie, who will be giving you a talk next week, correct? Mary Little, her name is, works with us. I don't know if you know her. We have one other co-worker that in the skeletal dysplasia team by the name Andrea. Andrea is not in the picture. She wasn't there that day. Mike Barber, you might know him. He's a geneticist, and Angie Duker works with Mike, and Colleen she keeps us straight. Particularly, she keeps Dr. McKenzie straight. And she's a research coordinator. Roger is also our research coordinator, and this is me. So thank you guys, and time for question and answers. I hope I didn't take too long.
Bueno, pues muchísimas gracias, doctora. Yo desde aquí te mando un aplauso muy fuerte al finalizar tu presentación. Y bueno, y el resto del equipo, ¿no? Como siempre ha sido una presentación muy clara, muy concisa, y lo que siempre además intentamos pedir con un lenguaje muy apropiado para todos los asistentes, porque hay profesionales, sí que los hay, viendo los participantes, pero hay un gran porcentaje de familias que sí que necesitan no solo que se les explique, sino entender, ¿no? Qué es lo que se les está explicando, cuál es la información que tienen que recibir, y bueno, pues como siempre ha sido fantástica, así que muchísimas gracias. Me ha hecho muchísima ilusión ver las fotos del Congreso del 2018 y también ahora el grupo de displasias con el doctor Mackenzie, con Lindito, bueno, en fin. Tenemos grandes recuerdos, pero que no solo quedan en el recuerdo, porque el año que viene tenemos nuestro nuevo Congreso Internacional, en el 2022. Así que hay que ir preparando agendas,
Awesome.
hay que ir preparando el ánimo porque son días muy intensos, pero días muy, muy bonitos para disfrutar todos. Así que, como no, recibirá la invitación oficial y formal, pero ya la está recibiendo aquí de manera informal, ¿no? Por nuestra parte, que contamos con usted otra vez con nosotros, porque siempre es un placer tenerla cerca. Así que muchísimas gracias. Nos han llegado varias por distintos canales, algunas preguntas. Algunas yo creo que puede ser que se hayan contestado a lo largo de la presentación porque han llegado en distintos momentos. De todas formas, yo las formulo por si acaso hay algún matiz que quiera hacer, ¿no? Sobre lo que están preguntando, y si ya ha sido contestado, pues nada, la respuesta es rápida y sencilla. ¿Le parece que lo hagamos así?
Oh, yes. I was looking through the
Muy
chat.
bien.
Yeah,
Algunas
some
están
folks
en
have,
español, muchas, entonces las decimos así y la traductora
yes.
se las puede pasar al inglés directamente, porque en el chat a lo mejor no entiende todas. Y hay varios chats por los que llegan, entonces, bueno, a ver si no se nos queda ninguna. Bueno, una de ellas es qué tipo de anestesia se recomienda en bebés con acondroplasia cuando se tiene que hacer una resonancia, que creo que sí que lo ha dicho al final.
So, yes, so there are two kinds of MRI. There's one called rapid screen. So rapid screen is a very quick run of pictures, and the infant does not need any MRI. I'm sorry, the infant does not need any anesthesia. That's the only advantage of rapid MRI, but oftentimes it is not adequate to see the structures that need to see clearly to determine if an infant needs surgery or not. So especially if the infant is really young, we would do a rapid MRI sometimes, and quite often the neurosurgeon will say, I can't make any diagnosis based on this. I need a regular MRI. And then the infant will need a general anesthetic. Now, and most commonly, that general anesthesia will need a breathing tube. Not always. If the infant is a little bit older, by that I mean around maybe 6 months of age, and is not snoring too badly once asleep, we might be able to manage without a breathing tube. But it's always safer to put a breathing tube in because, most everyone have seen what an MRI suite looks like, right? It is this long tunnel-like structure, and the infant has to go down all the way away from us, and we don't have our hands on the baby. So if trouble starts, it takes a few minutes for us to get the baby back in our hands. That is the main issue with MRIs, actually. Otherwise, if MRI is something that can be done like in an operating room atmosphere, we would try with our breathing tube first because there's no surgery being done. The baby just needs to be still. There's no painful procedure being done. But the concern with MRI is that an infant goes unprotected to the MRI tube-like thing, and they go quite a ways down. And so a lot of times we protect the airway, and maintain our ability to breathe for the patient because of that. Does that answer the question?
Sí, perfectamente, gracias. Mira, tenemos un caso particular, se lo formulo y nos dice qué le parece. Mi hijo de 16 años tiene una displasia esquelética llamada gerodermia osteodisplásica, con hiperlasitud cervical. Tuvo una cirugía de hernia inguinal con 6 meses sin saber de su hiperlasitud. En caso de que en un futuro tuviese que entrar en quirófano, el tema de la anestesia es algo que nos preocupa bastante como padres. ¿Sería conveniente que se le hiciese un estudio previo para presentar al anestesista en caso de que hubiese que hacer una intervención de urgencia? En caso positivo, ¿quién debería realizarnos ese estudio? ¿Y quién nos debe derivar?
Okay, so part of what you said in the end there got broken up. I couldn't quite understand.
¿La formulo de nuevo, Laura?
Okay,
vale,
so
perfecto.
So who takes care of him now? Who does he go to and on a regular basis?
Pues a nivel general está seguido, entiendo, yo que conozco un poco a la familia que formula la pregunta, a nivel de lo que es su displasia está seguido por el traumatólogo y por un equipo multidisciplinar experto en displasias esqueléticas. La cuestión es el tema específico de la anestesia, por dónde deben de moverse los papás, ¿no? O quién debe hacerse ese estudio para tenerlo ellos siempre, en caso de que tengan que realizar una intervención, poder presentarlo. Entiendo que es así.
Yes. So yes, I did. So it's not a difficult question to answer because we come across that quite often. So when the orthopedic surgeon that he goes to is that is a hospital, right? And they have anesthesiologists there, so they should interact. His last MRI, and sometimes they will do a CT scan, which is easier. The orthopedic surgeon will determine just how much laxity there is and whether the laxity gets worse with certain movements. So under anesthesia, we have to move the head and neck backwards more than going down like this. So that backward movement is called extension. And so they will provide that information quite clearly, that the laxity is worse or remains the same in the extension of head and neck. And that's the information anesthesiologist needs. Does that answer the question?
Vale. Entiendo que sí. De todas formas, como ahora mismo no pueden interactuar de forma directa todos los espectadores, bueno, saben que cualquier duda que les haya surgido nos pueden mandar un email al correo de la Fundación y nosotros te lo hacemos llegar a ti por si acaso quedase algún matiz sin contestar. ¿De acuerdo?
Of course.
Hay otra
yeah,
pregunta.
of course. And
Bueno,
here's my email.
hay otra pregunta de otra experta a nivel internacional en displasias esqueléticas, como es la doctora Virginia Fano, de Argentina, del Hospital Garrahan, que también la tendremos en breve por aquí, en cuanto la podamos engañar, entre comillas, para que nos dé otra de sus charlas. Pero ella formula una pregunta que es... tienen un paciente de 6 meses con acondroplasia y estrechez de tráquea, si das alguna recomendación.
Yes. So is she needing an anesthetic? Or you simply asking?
Virginia, sí. Virginia, ¿estás en el chat? Sí. Sí. Dice que va a necesitar anestesia.
Will be, is that the answer? Okay. Yeah, so I just recently got into this, and it's not uncommon. So the best way to first,
y requeriría resonancia.
First,
también, apunta la doctora.
Yeah. Okay. So is the surgery for foramen magnum stenosis? What kind of surgery?
¿Es por una estenosis, Virginia? No saben, de momento van a hacerle la resonancia. Entiendo que dependiendo del resultado de la resonancia será valorado estudiar la intervención. Entonces me imagino que la recomendación va orientada a la anestesia para la resonancia. ¿Es así?
Yes, yes, yes. So I'm assuming that this is
si no dice que te consultarán privado, no pasa nada. Pero entiendo que sí, que es con respecto a la resonancia. Pero tiene estrechez de tráquea, entonces ese es el matiz, entiendo yo.
So again, it's not that uncommon to see that. As the child grows older, the trachea will get better, but at 6 months, sometimes you get into not being able to pass a decent size breathing tube. And so if the anesthesiologist cannot pass at least a 3.0 breathing tube, then we, unless it is a real emergency, we will ask the procedure to wait another couple of months to see if that baby can then take a 3.0 breathing tube. Otherwise, you're talking going down to a 2.5 breathing tube, which is really tiny, which is what we call 2.5 breathing tube. We call it an unstable airway, not a good airway you want to send an infant down to the MRI with. But if it's an emergency, then you just do everything you can and still go ahead and do it. That answer the question?
Pues sí, sí. Nos contesta la doctora Fano que sí, que le darán la recomendación al anestesista. Gracias. Hay otros papás que preguntan, ¿la intubación con fibro...?
That would be helpful.
Vale.
Email these
Perfecto.
days is so easy.
Genial. Perfecto. Pues Le daremos, que me imagino que lo tendrá, pero le daremos, si no, tu correo a la doctora Virginia Fano, que seguro que también lo tiene, y en privado sí que podéis, eso puede ser interesante, que puedas hablar directamente con el anestesista si lo requieren desde el hospital.
Yes, yes. It's a little bit easier,
Bien, hay otra pregunta que pone que la intubación con fibroscopio puede causar broncoespasmos de alguna manera, porque el paciente haga algún movimiento al no estar totalmente dormido, o si no se le ha anestesiado la boca ni la lengua, o por alguna otra razón.
Yes, please. Yeah, so that's why fiber optic, not the other tools, the fiber optic bronchoscope intubation really is an advanced skill. So if the patient can be sedated, depends on how much sedation the patient can tolerate. You know, sometimes we sedate the patients to the point they're almost unconscious, but not all the way. And they are spontaneously breathing, meaning they're breathing for themselves. And we still have to numb up the nose and, you know, down behind the nose, and it goes well. But I can tell you that in my 31 years, it took me a few years to develop that skill. So that's where it makes a difference. It doesn't cause bronchospasm. It just causes coughing and uncooperative patient who will move around, which will make the procedure very difficult, because you saw that scope. It's like a little noodle, you know, it's just a tiny little thread-like thing. And at the end of it, there's a video lens. And if it moves around, you're now going to get the view of what you want to see. It's just gonna go show, you know, the teeth or parts of the mouth that's not what you're looking for. You're looking for the airway. Again, it is probably the most advanced intubation skill.
Sí. Hay otra pregunta que nos llega por otro chat que habla sobre si la obesidad puede influir de manera evidentemente negativa a la hora de anestesiar, de la anestesia.
Yes. So obesity is again, as you know, it's a common problem. It only has a negative impact if it is to the point that the patient is on fairly high levels of CPAP or BiPAP. And again, if carefully done, it's not as big a deal as a narrow airway. What we do with obese patients, it's not uncommon to see even teenagers who come for surgery who are somewhat obese and they're already on CPAP or BiPAP. We ask them to bring their CPAP or BiPAP mask. And after the anesthesia, after we take the breathing tube out, we immediately put them back on their CPAP or BiPAP, whichever one they are using. And that just has to be arranged, and it would normally work.
Más preguntas relacionadas también con los bebés. En esta línea están preocupados porque con frecuencia tienen que pasar por resonancias, por distintas circunstancias, ¿no? Y sobre todo en los primeros años de vida con las resonancias o con alguna operación, con alguna intervención, los papás están preocupados. Si todos los años pasar por una anestesia para una resonancia puede acabar siendo perjudicial para el niño. Aunque sea poca anestesia para solo una resonancia y no una operación, pero como es frecuente y prolongada en los primeros años sobre todo, si eso puede llegar a ser muy perjudicial para el niño.
So you probably have seen or heard about the relatively new information about neurotoxicity from multiple anesthetic, and it's only in babies younger than 1 or 2 years of age with multiple anesthetic, and it's not clear whether it even exists. Because the studies have not been conclusive. Because what happens is that the population that has been studied are premature babies who do not have skeletal dysplasia, but they're born before full-term pregnancy, and they have many issues and they need multiple surgeries. But they already have cognitive or developmental delays. So you never know whether it's from the anesthetic or from their own premature birth. And when I say multiple anesthetics, it's something like at least 7 different anesthetics within the first couple of years. So that's a lot of anesthetic. We also have been adding a non-neurotoxic anesthetic, if we can, to the baby anesthetic. So with an achondroplastic infant, if we can, we will add something called dexmedetomidine. It's a long word. The short word for it is Precedex, and that has no neurotoxicity at all. And if we could not do the entire anesthetic using Precedex, we would then add some Precedex to the rest of the anesthetic, and that way decrease the other anesthetic agents and do the best we can, to minimize possibility of neurotoxicity. But I have to say we continue to anesthetize babies because many babies even without skeletal dysplasia come for surgery, and pretty much surgical procedures, especially in children and babies, cannot be done without anesthesia. So they get done, and the current studies, there are national and international studies going on this issue. They have not come out with their results, not in any conclusive way. So we don't say that we won't anesthetize young babies for fear of neurotoxicity, because for one, surgery has to happen, and no one wants to, have surgery without any anesthetic. Now, MRI is a little bit different, but when it's done correctly, I think the risk is minimal from a neurotoxicity standpoint. I know that was a long answer.
No se preocupe, perfecta. Vale más que las cosas queden claras, para nada. Hay otra pregunta sobre la hidrocefalia. Dice que si los niños con hidrocefalia tienen más problemas a la hora de la anestesia.
hydrocephalus, if it is big enough that it has been shunted, they are a little bit more prone for, I mentioned the word opioid, remember, during my talk. Opioids are medications with things like morphine in it. So infants or patients with hydrocephalus can be a little bit more prone for respiratory depression from opioid use. So you just have to be careful. A little bit. It's not as bad. So again, there are many patients out there, especially patients with cerebral palsy. Now that's not a skeletal dysplasia, but they have hydrocephalus. They have a different kind of hydrocephalus, and they are much more prone for respiratory depression when opioids are used. So achondroplasia is not quite that bad at all.
Gracias. Quedan algunas, yo no sé, tampoco queríamos robarle mucho más tiempo. Yo quizás hacerlo una más y el resto enviársela si quiere por email, o tampoco queríamos abusar mucho más de su generosidad. Entonces, yo creo que si le parece, mira, podemos hacer una más, ¿le parece? ¿Tiene tiempo? Y el resto...
Oh, yeah, that's true. Yeah, no problem.
¿Sí? Muy bien. Ahí, mira, hay un caso que dicen que tiene un niño de 6 meses recién operado de descompresión del foramen magnum, ¿no? Que es una operación que desgraciadamente vemos que se hace asiduamente en los primeros años de vida, ¿no? Tiene 6 meses en este caso y preguntan sobre qué tipo de cuidado, ¿no? Qué cuidado tienen que tener después de la operación, y con respecto a la anestesia, entiendo, y también una vez que se despierta de la anestesia, también luego les hacen una resonancia posterior, si es también peligroso hacerlo con muy poco tiempo de intervalo, entiendo, ¿no? Si hay que espaciarlo más, bueno, pues un poco el cuidado que hay que tener una vez que despiertan o una vez después de la operación, y el tiempo que haya que prolongar entre una cosa y otra para no meter tanta anestesia en tan poco tiempo. ¿Qué opinas sobre ello?
So the infants after foramen magnum decompression, it only takes maybe 2 to 3 hours of anesthesia time in the operating room, and it also not very painful, and can be easily managed with non-opioid pain medication. They do go to ICU because it was the surgical procedure was close to the brain kind of thing, and the next day typically they will go to the regular floor, leave ICU, and needing MRI right after. I don't believe we do that unless there was some kind of an issue or the neurosurgeon is worried about a particular issue. I can talk to our neurosurgeon who does our achondroplasia children, their foramen magnum decompression, and see what he has to say, because it's a little bit outside of my area. But if the baby needs an MRI within the first week or something like that, due to it's some concern, then I don't think it is any more risky, even though if it's within a few days of the first anesthetic, because the breathing tube was used the first time, and now you have to put the breathing tube down again. Again, that croupy sounding cough or croupy sounding cry afterwards will be more common. And so we are very quick to treat that even before we pull the breathing tube out, expecting that that baby will have croupy cry, croupy type of breathing. So it's good to anticipate that and be ahead of the game,
Muy bien, pues con esto damos por finalizado ya, bueno, pues volver a agradecerle, doctora, todo su tiempo, toda su dedicación y toda su cercanía y cariño como siempre. Si le parece, las preguntas que nos han quedado por diversos chats se las podemos hacer llegar por email y usted pues tranquilamente pues las contesta cuando pueda y nosotras se las hacemos llegar a las familias como siempre, ¿no? Estamos encantadas de haber pasado este tiempo con usted, más informada si cabe, ¿no? Y con un poquito más de luz, ¿no? Sobre todas las cuestiones y dudas que nos surgen habitualmente y que también nos llegan a la Fundación. Estamos en contacto, seguimos en contacto como asesora clínica que la tenemos ya de la Fundación y esperando y deseando verla el año que viene en nuestro próximo Congreso Internacional, ya va en persona para disfrutar más si cabe, ¿no? de su conocimiento, de su compañía. Así que muchísimas gracias, que tenga un buen día, resto de día allí y nos vemos. Muchísimas gracias por todo, de verdad.
My pleasure. Yes, and yeah, don't hesitate to email me. I just want to say one thing about my email. I have two email addresses. One is mary.theroux@neumos.org, as you see on the screen. Sometimes from abroad, that particular address is problem. So what Fanny has, what ALPE has for my email, I think is better. I can correct this and show you. It's simply mtheroux@neumos.org without mary.theroux. So do you want me to take this slide and correct that and show you? My email,
vamos a ponerlo, mira, yo creo que podemos ponerlo.
Okay.
Yo la tengo aquí, la voy a escribir en el chat, ¿de acuerdo? Mira.
Okay, awesome, yeah.
A ver, la que usamos nosotros en ALPE. Pero es la que tenemos. ¿Cuál es la otra que... Fanny, ¿cuál es la otra que dice para ponerla en el chat?
Fanny is...
I'm looking now, sorry.
mari.theroux@neumos.org. Yo creo que es la misma la que usamos.
Mary, it's the same one we have.
¿Y nos va bien?
It's the same one you have in the slides, the one we use.
Sí.
Oh, really? Okay.
Yeah, it's this one.
Sí, es la que tenemos nosotros, la de la diapositiva. Y bueno, de momento nos va bien, pero bueno, yo he dejado en el chat el correo de la Fundación por si, bueno, por si alguien no lo tiene, para que nos haga llegar las cuestiones y nosotros te las enviamos.
No problem.
Mary.
Yeah. All right, you guys.
No.
Chicas.
Pues muy bien, despedimos esta charla, despedimos esta comunicación y nada, deseamos veros la semana que viene junto con el doctor Mackenzie y de todas formas os enviamos toda la información vía email, a través de nuestras redes sociales. Ya sabéis que os lo hacemos llegar de diversas maneras para que estéis informados. Muchísimas gracias a todos. Un beso muy grande.
Thank you, Mary. Thank you all. Bye.
Thank you. Thank you all. And all those who I cannot see, I really appreciate you being there, and do not hesitate. I do have frequent meetings with other dysplasia groups as well. It's not a problem. I don't mind spending my time. I love it. So good night for now.
Buenas noches. Buenas noches.
Okay, bye. Bye-bye.